Continuing with this high-yield cardiology review, we will now focus on myocardial infarction evolution, key pharmacologic effects of alpha-adrenergic agonists, and important clinical scenarios involving hemodynamics and cardiac function. These concepts are essential for both exams and real clinical understanding. Evolution of myocardial infarction occurs in several stages. The final stage of healing begins approximately 2 weeks after infarction and involves increasing deposition of type 1 collagen. Fibrosis continues until about 2 months after infarction, resulting in a dense collagenous scar composed primarily of type 1 collagen. This scar can be identified grossly as a firm gray-white lesion and microscopically as collagen replacing normal myocardium. Time after myocardial infarction and predominant light microscopic changes. 0 to 4 hours no visible change. 4 to 12 hours wavy fibers with narrow, elongated myocytes. 12 to 24 hours myocyte hyperiocinophilia with pycnotic nuclei. 1 to 3 days coagulation necrosis with loss of nuclei and striations. Prominent neutrophilic infiltrate. 3 to 7 days disintegration of dead neutrophils and myofibers. Macrophage infiltration at border areas. 7 to 10 days robust phagocytosis of dead cells by macrophages beginning formation of granulation tissue at margins. 10 to 14 days well-developed granulation tissue with neovascularization. 2 to 8 weeks progressive collagen deposition and scar formation. Direct effects of alpha-adrenergic agonists. Alpha-1 mediated effects: vascular smooth muscle contraction, mydriasis, increased internal urethral sphincter tone and prostate contraction. Alpha-2 mediated effects: central nervous system mediated decrease in blood pressure, decreased intraocular pressure, decreased lipolysis, decreased presynaptic norepinephrine release, increased platelet aggregation. Case 4. A patient receives a drug that increases systolic and diastolic blood pressure with a reflex decrease in heart rate. These findings are consistent with a selective alpha-1 adrenergic agonist such as phenylephrine or methoxamine. The correct answer is decreased atrioventricular node conduction velocity. Activation of alpha-1 receptors in vascular smooth muscle causes vasoconstriction and increased systemic blood pressure. This increase is detected by baroreceptors located in the carotid sinus and aortic arch. Baroreceptor activation leads to increased vagal tone. This results in decreased firing of the sinoatrial node, slowed conduction through the atrioventricular node, and reduced myocardial contractility. This explains the reflex bradycardia seen after administration of alpha-1 agonists. Case 5. A patient with hypertension, diabetes mellitus, and hypercholesterolemia presents with decreased left ventricular function. Echocardiogram shows hypokinesia of the anterior wall and a reduced left ventricular ejection fraction of 35%. After coronary artery bypass grafting, the hypokinesia resolves and the ejection fraction improves to 50%. The correct answer is hibernating myocardium. Myocardial hibernation is a state of chronic ischemia in which myocardial metabolism and contractile function are reduced to match decreased coronary blood flow due to significant stenosis. This adaptive mechanism prevents irreversible myocardial injury. At the cellular level, there is decreased expression and disorganization of contractile proteins, altered adrenergic signaling, and reduced calcium responsiveness. These changes lead to decreased contractility and systolic dysfunction. Importantly, restoration of blood flow through revascularization allows recovery of myocardial function, explaining the improvement seen after surgery. Case 6. A patient undergoes surgery and afterward demonstrates a rightward shift in end diastolic volume on the pressure volume loop, indicating increased preload. This hemodynamic change can occur with infusion of normal saline, blood transfusion, or conditions such as renal failure that increase intravascular volume. The correct answer is normal saline infusion.